There, how are you? I am Dr. Lee. I am with the Secours Medical Center and Cancer Center. I am a colorectal surgery specialist. I have been managing colon cancer diseases for over 25 years in my practice, and just want to inform you about the importance of colon cancer screening. This is Colon Cancer Awareness Month, and as you all know, colon cancer is the second or the third leading cause of cancer deaths in males and females, respectively. And it's very important that we screen individuals who meet the criteria for colon cancer screening at the appropriate time in order to minimize or even eliminate the risk of colon cancer. I'm here to happy to be here and more than happy to answer any of your questions or concerns you may have. And if you feel free to call me and chat with me, and I'll be happy to answer all your concerns.
Who should be screened for colon cancer?
Well, the guidelines is that if you're anywhere in the age of 45 to 50 or beyond, it is important that you talk with your family physician to, discuss the importance of colon cancer screening, and the doctor will refer you to a specialist who will do the colonoscopy examination. Colonoscopy examination, as you know, is a safe procedure nowadays performed by competent endoscopists. It requires that you fast for 1 day and take a special laxative to actually cleanse your colon. And you come the next day with a driver, and it is a outpatient type of procedure. You will come in, and most likely the doctor will give you some medications to make you very sleepy or outright sleeping. And during that time, you will have the examination performed. And after that, the doctor will go over the findings with you. And it's very important because colon cancers pretty much all start from benign lesion called colon polyps. And if we can catch these polyps at a small early stage, your endoscopist or the doctor doing the colonoscopy will be able to remove that, thereby eliminating any chance you will develop colon cancer later in your life. So as you can see, it's very important to understand that we do have the technology and the capability at this time to pretty much manage or potentially eradicate colon cancer threat for you. And again, it's very important that if your doctor recommends that you go ahead and have the colonoscopy examinations, do you consider this very seriously, because this is the best way we can to prevent colon cancer.
Does the polyp, is it able to be removed during the colonoscopy, or is that a separate procedure?
The vast majority of polyps that I've encountered, I was able to remove during the time of the colonoscopy. Certain circumstances, such as if the polyp is quite large or the configuration such that there is increased risk of injury to the colon, then your doctor may recommend that you see a specialist, someone like me, who will discuss other options of removing this. That could be a little bit more invasive removal of the polyp. And also, it is important to understand that if you do have a cancer diagnosed at the time of the colonoscopy, that your doctor will refer you to a specialist like myself to discuss surgical treatment for the colon cancer. Again, it's not a good thing that you have colon cancer diagnosed during your colonoscopy, but imagine this: had you not had the colonoscopy examination, then most likely, if you wait and procrastinate, it isn't entirely possible that years down the road you will develop symptoms of abdominal pain, bleeding, bloating, weight loss, and changes in your bowel habits. At that time, quite often the case, it is at a very advanced stage where surgery may have some limited role in treating your cancer. So again, if you have a screening colonoscopy examination, you're perfectly what we call asymptomatic. You don't have bleeding or weight loss or other symptoms, and we find a cancer. Usually they can be at an earlier stage, and we are able to render treatment quite effectively nowadays, a combination of surgery with chemotherapy or radiation therapy. But again, cancer statistics have shown that over the past decade, the survival from colon cancer has been increasing steadily, which is great news. That pretty much speaks to the fact that the treatment for colon cancer has advanced a lot in the past several decades.
Avery asks, my husband is 30 and is having a lot of colon/rectum pressure. Is it too early for him to consider a colonoscopy?
Well, I don't think so at this time. We would like to have individuals, again, as I mentioned, 45 to 50, who are completely asymptomatic to have a screening colonoscopy examination. If you are having any of these symptoms, such as bleeding or pain or bloating or these issues, as was mentioned by the question, then I think it's very important for you to discuss this with your doctor and most likely proceed with a colonoscopy examination. I think it's quite important because if we do find nothing wrong with you, that's fine. But if you do find something, it is imperative that we treat this early stage so that you will have the most maximum cure.
Talisha asks, what's the youngest patient you've had in your career diagnosed with colon cancer?
Unfortunately, when I was at the Henry Ford Health System, roughly about 20 years ago, there was a 17-year-old young man who came in with just these symptoms that we talked about. He was having progressive abdominal pain and weight loss, bleeding. He was quite anemic when we saw him. And so he was admitted from the emergency room, and we saw him in consultation. Unfortunately, colonoscopy later revealed that he had an obstructing colon cancer. And when we did further studies with the CT scan, he had diffuse metastasis, so spread all the way to the liver and lungs, and he essentially had terminal cancer. Now, he's been complaining about these symptoms for over, I would say, 4 to 5 years, but when you're a teenager, very few pediatricians or even surgeons or specialists would suspect you have colon cancer. Again, his symptoms when he presented to us were terminal symptoms, and this highlights the fact that if you have any concerns about your, the symptoms that you're having, it's very, very important to discuss it with your doctor. And also, if you're not sometimes satisfied with your doctor, certainly it's a good idea to get a second opinion or even with a specialist.
If you have family history of people who've had colon issues, should you get a colonoscopy earlier?
Much earlier, because we categorize individuals into 2 groups. One is what we call the normal risk group. These are individuals who have no known family history of colon cancer, never had any previous colonoscopy with polyp removal. These individuals, if you do, let's say, a first colonoscopy at age 50, generally speaking, and they have pretty much a normal colonoscopy examination, we recommend these individuals have a colonoscopy every 10 years. However, the higher risk individuals are the ones typically who have family members with colon cancer. We are very concerned about the family history, such as let's say your father had colon cancer, his father had colon cancer, all of his brothers had colon cancer. We strongly suspect a genetic component or hereditary component of colon cancer. These individuals should be screened at a very early age, even as early as mid to late 20s, and they should be screened quite frequently, sometimes as frequently as every year if they have multiple polyps removed at the time of the first colonoscopy, or at the least every 3 to 5 years. So, we would like to identify those individuals who we consider to be high risk and render treatment much more frequently and screening much more frequently.
You're a colorectal surgeon. What kind of surgeries do you do?
I do, basically the bulk of my surgeries are dealing with colon and rectal diseases. Number one would be colon cancer. We do see quite a high frequency or incidence of diverticular disease with diverticulitis and abscesses. Those individuals frequently require surgery. I also see a lot of patients with inflammatory bowel disease, that is Crohn's disease, and ulcerative colitis most commonly. And I also do a lot of surgeries regarding anorectal diseases such as hemorrhoid disease, anal fissure disease. I've also treated many patients, unfortunately, with anal cancers. These individuals are sometimes not easily or diagnosed early because a lot of the symptoms they complain of mimic hemorrhoid disease, and sometimes they could be rendered as having hemorrhoid disease rather than serious anal cancer diseases. So another recommendation is the fact that if you think you have hemorrhoid disease and it seems to be chronic, lasting over a month or 2 months, it's important for you to discuss this with your doctor and then maybe have a referral to a colorectal surgery specialist to rule that particular disease out.
What's the difference between open and laparoscopic surgery for colon cancer?
The traditional surgery that we have done is an open surgery, whereas we make a big incision and we actually remove the part of the colon that has a cancer segment along with the associated lymph nodes and the blood vessels. That would be considered the gold standard. And the benefit of that surgery is the fact that the surgeon can palpate every corner of your belly cavity and look out for any potential for metastatic disease or other abnormalities. The laparoscopy approach has been very popular for the past, I would say, 10, 15 years. And the benefit of that is that we make a very small incision. And when I do laparoscopic surgery, I use what we call an applied medical port and a one small 5mm incision to perform pretty much all of my laparoscopic surgeries. Because we have very accurate CT scan technology nowadays, as opposed to maybe a couple of decades ago, we are able to determine whether or not you have cancer spread already to especially the liver or other distant organs early on. So if we find no evidence of that, we are able to perform the laparoscopic surgery. Again, the benefit of that is that you end up with a much smaller incision, and the recovery tends to be much faster. For instance, most people do recover from colon resections after laparoscopic surgery within about 3 to 4, maybe up to 5 days at most. And the recovery at home is much shortened by half. It used to be about anywhere from 6 to 8 weeks. I've seen patients go back to work in about 2 to 3 weeks, or more commonly 3 to 4 weeks. So there's the advantage. The disadvantage is the fact that I personally do not have my hands in the abdominal cavity to palpate every corner of your belly cavity. So what I do is I individualize the patient's circumstances. If I feel that there is a strong risk of that patient's having metastatic deposits, then I strongly recommend that maybe we consider a laparoscopic assisted or open surgery. If it's a typical patient that really shows no evidence of any metastatic disease, then I will strongly recommend we go to laparoscopic surgery, which is what most of the patients prefer at this time.
How fast does a polyp become colon cancer?
That's the thing. It can take up to a decade before a polyp can progress to cancer. So we have a very long, sort of a time sequence where you develop a small polyp, which becomes a big polyp, and the big polyp becomes a frank cancer. However, the problem is the fact that while the polyp is growing inside your colon, you are completely asymptomatic. You don't know. Oftentimes you don't see any blood, you don't see any symptoms whatsoever. So just the fact that you feel great, you never felt better in your life, and you're 50 and you're great, does not mean in any way that you don't have a polyp or early cancer, growing inside your colon. So again, that's the importance of why a screening examination is so imperative, and that the doctors, myself, and your family physicians strongly recommend you get your colonoscopies when you become of age.
If colon cancer does spread, where does it spread to?
Well, generally speaking, this is how the colon cancer spread. We go from stages, stage 1 to 4. Stage 1 is when the cancer is very early. It's limited to the inner lining of your colon. These patients are generally asymptomatic. You don't really see anything. Occasionally, you may see some bleeding streaks if you have a bowel movement. But again, these are individuals who really don't complain much about any abdominal symptoms. Stage 2 is when the cancer progresses a little bit deeper into the colon wall, involves pretty much most of the colon wall. These are much more advanced cancers at this point. But the distinctive feature with the other stage, the next stage is stage 3, is that the lymph nodes that are surrounding the colon segment in question where the cancer is have not been involved with colon cancer spread. So these are stage 2 cancers. Stage 3 cancers is that identical to stage 2, except the difference is the fact that there are lymph nodes now involved with cancer. Cancer likes to spread into what we call the lymphatics and into the lymph node channels embedding into the lymph node, much as it does in breast cancer or other cancers. And then from there on, they will progress distantly, mainly to the liver and sometimes to the lungs. So when you have cancer spread already to the liver or lungs, these are considered to be stage 4 cancers or advanced metastatic cancers.
What's the advantage of a colonoscopy over other screening methods for colon cancer?
Well, I think there are other sort of options there are for individuals who are concerned about them. One is common studies that we use is stool hemocultic studies, where you submit a special kind of smear of your stool, and that would determine whether or not there's blood there or not. We have other more advanced studies like the FIT test or the fecal immunostain or studies, but ultimately, the issue is the fact that we don't exactly know what the false positive rates are or the false negatives. By that I mean that even if you have cancer, it is possible that these studies may be negative, or for that matter, if you have we find out later that you have no evidence of any colon cancer or colon polyps, these studies can actually be falsely positive. However, I think, as I always emphasize to my patients, that some tests is better than no test. I think it's, if you're not inclined to have a colonoscopy examination, this is something to discuss with your doctor. There are other studies such as a CT colonography or the virtual colonoscopy that you get with imaging or X-ray techniques. I'm not quite sure at this time. I think many of the insurance companies will not cover this, whereas a screening colonoscopy examination for all individuals over the age of 45 to 50 will be covered by your insurance provider. Having said all that, unfortunately, if any of these studies confirms that the study is either positive or there is suspicion that you may have either colon polyps or colon cancer, then it is, it's essentially very important to proceed with the colonoscopy examination. So again, the benefit of the colonoscopy examination is it can be a one-stop type of study, whereas you have an examination done. If the competent endoscopist sees that you haven't completely normal colon, then you're okay with the average risk individual for 10 years.
What are the risk factors for colon cancer other than family history?
Well, I think there's studies that's showing that we have known for a long time, back, when I was a medical student in the 1980s, that diet has a lot to do with colon cancer incidence. For instance, like the famous study was performed for Japanese immigrants to Hawaii, where they looked at the first generation, second generation, third generation. When they looked at the dietary habits of the first generation Japanese Americans, immigrants in Hawaii, their diet consists of mainly fish, like they are used to in Japan. Their incidence of colon cancer was extremely low. By the time the second generation came in, the incidence of colon cancer was not quite as high as the average American individuals, but they were becoming much more higher than the first generation. And when we looked at their dietary habits, they were now acclimating to the local diet, heavy in red meat and high in fat and much less in fiber. By the time we see the third generation, their incidence of colon cancer is no different or even higher than the average American individuals. And from that epidemiological study, we have concluded that their diet has maybe something to do with colon cancer. We have not been able to identify the exact link. How does this happen? Until recently. What happened was that there was a study from UCLA where they looked at laboratory mice, and in that study, they fed some of the experimental mice diet high in cholesterol, or they altered the genetics of the mice so that they will develop more higher levels of cholesterol within the mice itself. And what they found was that at the intestinal level, at the stem cell level, there's a high turnover, meaning that there's a lot of proliferation of these stem cells, and this is where colon cancers or colon polyps arise from. And so they conclude that yes, there is a direct link, a genetic link between high cholesterol diet and incidence of colon cancer. It's too early to say whether taking statin drugs such as Secours will reduce your risk of colon cancer, but it does highlight the importance. There is increasing and convincing evidence that poor dietary habits will contribute to increased incidence of colon cancer.
No more questions.
You all? It's all set? It's all